especially this afternoon, it's been around data. Can't hear. Shall I just touch my lip? Is that a bit better? Yeah. Put on my nose. Anyway, so yes, data. That's all we've sort of heard this afternoon, and I think that's pretty much where I live at the moment in terms of that space. And I've kind of got two fairly unique roles. My sort of main role really is a CIO, but that's in a GP federation. So it's not from an ICB perspective, it's not from a trust, it is straight out of general practice and supporting practices within my area. And the second part of that, and because of it really, we set up a subsidiary there to look at primary care analytics more broadly. And that was really to look at the heart of general practices data and use that in a way that would support practices to do what they need to do with it. And I think one of the things I want to talk through today is actually how we've done that, what we've created. And actually some of it will sound probably more complicated than it needs to be, but the reality is when we did start this, it was just me, it was about 4 or 5 years ago, but we did it just as a sole person as opposed to having a massive team to do it. So I think the first thing really is just a bit of context. So I am indeed a country bumpkin that comes from Herefordshire, which is an unexpected place to get any form of innovation out really, but we are seeing more and more of it. Herefordshire is about 204,000 patients. So the federation that obviously I'm CIO for, we support 19 practices. There's 5 primary care networks within that. And we've got obviously this one GP federation that supports the whole patch. And I think that's really useful for us because it does mean that actually we can access all the data, it's anonymised, it's aggregated, it's nice and safe. But it gives us that sort of basis to really work from. It means that we can support practice at both the practice level, but also then through that sort of leveled approach of PCNs to a place. And there was some work I was doing with a couple of years ago that was then across Worcestershire as well, so we have a lot of data to work with and the measurement spot a lot more. But I think what we were trying to look at really then is how do we start to make PHM? We've heard PHM loads and loads of times, it was a buzzword, we're working with CCGs and ICBs around PHM strategy and this whole idea of how we should change the world. But it doesn't always have to be like that. Actually PHM can be down to one single patient, it can be up to 204,000 patients, but it's about making that impact, that actionable insight that we can go and do something with. And how do we sort of get that, in this case, identification to intervention, using the data to really make a difference to patients' lives. And I think what we found is obviously we started to build up, we all use EMIS, so actually we're really fortunate, but 90 practices all on our EMIS, which is fairly unique, and actually across our ICS everyone's on EMIS, so if there's something goes wrong, then we're all affected, which is a shame, but fundamentally it means accessing the data is really key. And I think what we found from that then is the tool that I'm going to talk through today, which is one of the things that we created, actually hosts 54 million data points. So it takes a lot of patients' data in a safe way, but it does mean then we've got a lot to work with. And in this case, we, over time, built a team to do what we needed to do with it, and actually what it allowed us to do was demonstrate the benefits of being able to have access to this data, what we could do with it, how we could implement PHM, and how we could support practices, PCNs, and wider. And that sort of benefit realisation allowed us then to invest in a larger team. So what does that team look like for us? I think it's just useful to sort of allow you to see how we sort of structured ourselves. I'm not saying, so this is a bit I think people tend to look at and go, well, it's great, but you need a resource for that, you need investment for that. And yes, we did, and it has been over time, but actually that investment came from the PCNs. It wasn't, we didn't get anything from the ICBs, didn't get anything from the trusts. It was very much a case of our own PCNs all benefited and they invested themselves into it. And so what we found is obviously the team that worked for us is, my team is predominantly general practice experience. Myself, I started in general practice as a receptionist over 10 years ago and sort of came up to there, so it allowed me to see what it's like to work in a practice, made to office manager, and then really started to understand what it's really like to work in a practice. From an administrative function, but you start to see how it runs, how it works, how we use things, what staff can do, and how we can start to think about some of the efficiencies, but also getting the complexities around this funny thing with PHM is that we're in a time where we're looking at capacity and access and how we haven't got enough capacity to do anything or we're really busy, and yet everyone's pushing PHM, less shift prevention, which is ultimately going to result in more work, which is an interesting one because how does that factor in there with the capacity and access side of it? So some of the things we are trying to do there is look at PHM in a way that means that those patients that are coming in, how do we do that in a different way? How do we start to think of group consultations or patients that we're not reaching, but actually the ones that are sort of need the support, and we're using it that way. So the team that's sort of grown really was, we've got data scientists of old, obviously they're not from general practice background. We've got data analysts that are from general practice backgrounds, so tend to be your IT leads, quad leads. Myself, and we've got head of analytics who was also from general practice, but it allowed that sort of understanding. The work coming from an NHS perspective or a CCG perspective or an ICB perspective now, we could understand the nuances within the data and what we could do differently about it. And also make it easy to have those conversations around how we're using it. And so obviously because of that then PCNs locally recognise the sort of the importance of it and the value of it and really started to build that into it. We have now got about 15 people within the team, which is pretty amazing really. We actually have teams bigger than some of the trust teams. But obviously what we did with that team is developed dashboards, tools, searches, ways of working, training, developing staff, data literacy, and it meant that we could help those PCNs really understand what to do with the data, how to use it differently, and even the questions to ask around it. So from my simplish Herefordian mind, I thought, let's try and make PHM slightly simple. We've seen loads of triangles and pyramids today. Well, I think from a PHM perspective, from an analytical perspective, we see data going through a bit of a flow. We start with raw data. In this instance, we've got 54 million data points, sounds a lot. But that's the data. You can't do much of that. It sits in a data warehouse. You're like, that means nothing to me. So we start to think about turning it into information, which is a bit then where we get some visuals and some graphs. People can start to see broadly how I compare to this practice to another, which patients are doing better than others. And then you start to bring the knowledge in, you start to get that interactive side where you can start to really granularly detail, break down and understand which bits we need to focus on a bit better. And then you get to this insight bit, which is that bringing it together a bit, talking with the clinicians, bringing in, strategic sides of thinking and how do we do things differently, how do we use all this information we've got and how do we turn that into an insight that means we can make an impact to patients. And then you start to bring in, you start to bring in the digital innovations, the clinical guidance and interventions, you bring them together and think about, right, let's make a difference to a patient or a set of patients or a whole population. And ultimately, the point of this is to improve patient outcomes. And then there's one bit at the bottom here which we tend to forget about quite often, everyone really does, is that evidence, that evaluating what we've done, does it even work? How many projects have we done where you then think, yeah, that felt like it went well, and then it really did, but it was a waste of money. But actually, the evaluation of it is incredibly important. So the case study I want to sort of take you through today really is, we've created this tool that was very local, it's something we did in-house, so we didn't have to go out to anyone. We used Power BI, which is something we taught ourselves initially. But essentially what we wanted to look at was designing something that allowed you to see a whole population. You could see the whole place, every patient within it. And in this case, we started to look at health checks. And so it seems like a relatively boring one to focus on. We've done other things, but health checks seem to work really well for us because we had a program at the time that was starting to look at, let's get health checks out into the communities, and the inequalities, where would we go, where would we put a bus, which places are going to be impactful, which places do we need a different communication method. And so we started to focus in on that. We then worked with the service teams doing how they would communicate and provide those health checks to the patient cohort. The team then took that care to the communities. They took a roving bus out, went to different places, obviously advertised it, and started to see patients in the community as opposed to expecting them to come to practice. And as a result, patients received health checks and follow-ups in a place and time that's convenient for them. But the point of all of this is that we use the data to determine that. So this is fundamentally what the tool looks like. There's a lot of text in here, so if the slides get shared after, that's kind of the reason for putting text in. So this, for us then, what we can see is we've already got it mapped out in terms of who hasn't had a health check across Herefordshire, We can see, obviously, we've got some of the eligibility criteria there in terms of no long-term conditions between the ages of 40 to 74. What we can now see is I've got 67,000 patients that need a health check. The average age of those is 56. I can start to see what the BMIs look like. I can start to see what the age banding looks like, which obviously in this instance we expect more lower ages. Where there are IMG deciles in. Now, I don't know if you know it very well, but we're not overly deprived, which does throw off some of our figures in terms of that core 20. The core 20 is a localised version for us. This is following the national one. We can see patients by Rockford score. We've obviously got, I think we mentioned it earlier in terms of what the average GP contacts is. I think we were looking nationally, sort of guidelines was around 6 or 7 per year in terms of appointments. We were on about 6, that's about right. And then we can start to see the ethnic grouping. Obviously we're not an overly diverse area either. But we can start to really understand now, okay, this is the type of patients that we're looking for. Because what we can do, this is where they are, and now we can understand things slightly differently. Within this then, so you've got 2 different areas within this. So the whole thing was designed to be interactive. You could then filter over things, you could hover over things and take the numbers. We are notorious, we just looked at the map, which is obviously usually the most interesting bit, I think. We are notorious, especially in our area, for focusing stuff in the city, which is there. Now, that usually makes sense. City, easy to get to, why wouldn't we do that? And it just seems to be services there, so let's do that. But actually, in this case, and what we find in a lot more cases now, is we have got these pockets of areas that we should be focusing on. So, would I go in the city there? Yeah, I might go in the city because I've got this dense patch here. But actually, this whole area here is a bit worse. So, would I really go here? And the other thing that Herefordshire is we're quite a rural, sparse county as well. So, you know, here to here is probably about an hour. Now, I can't expect patients who would need a health check or need some form of visiting some sort of service to have to travel an hour to get to there and then. We found the whole thing of care navigation. We were finding patients and we're trying to offer pharmacy and say, go see a pharmacist instead. They're like, yeah, that's great. That's going to take me 45 minutes to get to town and 45 minutes back out to potentially go and get some paracetamol. That doesn't seem to make sense to me. The other navigation is we didn't realise that the majority of our patients who would need a pharmacist worked in town, so it makes more sense to not for it. Anyway, so this allows us to really understand where we should be starting to put those roving buses. We didn't need a service in the city centre anymore. Let's get a bus out to this area, and let's get a bus out to this area, and this area here. Because actually we've got these populations that could benefit from it that are actually going to struggle to get to where our usual health check services are held. So the map became really useful in terms of understanding that. And then what we've got here then is this sort of idea of what are these common themes in these patients? What are we seeing? So when we've got things like people that need reviews, what other things have they got going on with them? Is it just one thing they need reviewing for, or is it a cluster of things they need reviewing for? And obviously within our health checks now we can see that we've got a large proportion of our patients who've got depression that need a health check. Are they less likely to go into a practice? So let's go there. We've got a large proportion there for asthma. We've got AF, which is in there surprisingly. They're obviously low numbers because obviously some of them won't be eligible, but you can start to see how actually we need to be thinking slightly differently about it. We've got of those patients, which originally were 60,000, you know, we can see that over 10,000, 15,000 of them smoke as well, probably more, we know it's under-coded, but we can start to see that coming through. Interestingly, I always thought this would be a lot more, is we can also start to see what that breakdown of male and female visits look like and weight status. So we start to be able to get all this information about it to really understand how we would do this program of work different to what we would have done previously. And so we start to look at how we put that in action. So how do we now start to use this data, do something different with it? We've got access to it, it's interactive, anyone can use it. We've got the general practice sort of analyst expertise to be able to talk the teams through how to do things differently. So how do we now put that into action? And ultimately, it was kind of as you'd expect. We had a change team as such, or a program team, or you had individuals from practices who were particularly keen on doing it, but you obviously needed some form of clinical champion, we needed program management, and it was obviously built into part of the service that we provided. But the important thing for us was ensuring that the analyst was there from the beginning, that we were talking about the data from the beginning, understanding what we would do with that data, not just jumping into usual conclusions of, well, I need to put a service in place, let's put it into the city centre because it's nice and close to us and we can manage that better. That's not a good idea. Let's not do that in this instance. Let's go put it in the south instead. And we were able to have those conversations. We were able to then make this more of a data-driven decision-making process as opposed to that gut feel of, well, everything's here, let's just do it here instead. And that was really important for us because obviously it meant, one, that we were being listened to, but really did mean that the teams were looking at the data to understand what they could do differently. And obviously in this case, identifying cohorts of patients and areas prioritised allow that team to focus in the areas that they needed to, as opposed to go into areas that wouldn't have necessarily needed it. And I think we're all too quick to sort of, we know we have champions across practice that are really keen to do these types of things, but they tend to be in the practice that are doing better. And if they're doing better, they tend to have done more health checks, in this instance anyway. And it's not those ones there that actually are the ones that needed the health checks. We need to be going out to places that hadn't had that experience. And so that's obviously what this allowed us to do. It allowed us to evidence one that, okay, let's not go here, we need to go here instead. And obviously that has the highest level. So those LSOAs have the higher levels of patients who require health checks, meant we could take care to the patient, which obviously resulted in higher levels of uptake. And then the key thing I think is off the back of it. It doesn't stop there from a data perspective. We've obviously done that initial piece of identifying those patients. And now it's a bit of, well, now we've identified those patients, what do we do about it? What do we understand from what we've identified? And so with then we'd obviously built the second part to any form of identification tool was the evaluation bit, the sort of monitoring of it. Could we understand the progress that that service had provided or delivered, or just generally, the same principle applies across anything you do in practice, really. You do a cough and understand, okay, well, this is our cough stuff, okay, what have we done to make a difference here, instead of your standard sort of how am I running a page, on a driving page. So this one then allowed us to see, okay, let's look at those patients we've seen. So at this point in time, we've seen 2,266 patients. How does that split down across the PCNs and where we were expecting to go to? We could then start to understand, okay, well, those patients that we had seen, what's the Q-risk scores within them? And of those Q-risk scores, then what were the outcomes of those patients? So we could see no Q-risk recorded. So some of those then have been signposted to diet, health, education, equipment loans, referrals, weight management. It just allowed us to start to understand where those patients were going off the back of it. We could then start to see the proportion of where patients were going. So the majority here of diet, health, education. And also see then that we had other brief education sessions and referrals, weight management. That was the general sort of consensus of where those patients went to. And then obviously what we've got is the demographics of those patients. So starting to understand, one, what we have seen, but then two, what we haven't seen. And that was also a key thing for us then, was to understand what we haven't seen these types of patients. Do we need to do something for those patients? And obviously what we have as well identified here is that the alcohol consumptions, smoking status breakdowns, cholesterol levels, and then the BMI dynamic breakdowns as well. So we really started to draw it all together. This part will then also allow us to sort of understand where we'd invited patients, so where they were sat, where we hadn't invited patients, where we needed to invite more patients, or the opposite now, where we had invited patients and we had a high uptake of those invites. And there's something around how we then use things like ActiveRx to communicate in different ways. How do we sort of send texts that are slightly different? Because in one area we've got more affluent, perhaps the education levels are better, so we would expect a different type of comms to potentially where we've got poor health education. So it's all of those things that we can start to really build into this. And then the last bit really for me, the last bit really for me is the challenges. So, quite clearly this wasn't easy. It has taken us 4 or 5 years to really get this up and running the way we wanted it to. I mean, the benefit is it now means that we've got it, so others done it as well. But the challenges that were definitely faced throughout many of these things, they're fairly generic in terms of trying to do one sort of project and finding difficulties across them all. So it's definitely the engagement. Getting the right engagement from the start. It's really tricky to go out on your own if you haven't got the right things and the right people being able to support that. And that's with any service, really. In a health check case, obviously it's a case of, well, we need a service, but we need to find the right engagement with that. We need to engage with communities to ensure that we've got the right people coming, but we also need to ensure that we're going to the right spaces and the right centres and all of that sort of stuff. You're getting the right clinical engagement to ensure that we're doing things safely, but also there is a true genuine reason for doing it in the first place. So engagement is always difficult, and obviously a lot of the time we've got to work with. It's not usually accompanied with funding, which is very frustrating, but we do have a lot of people that are really engaging in such things, so it's definitely finding them and hoping on them. Capacity is clearly something we'll hear time and time again. This is a chapter I'm financial for this, I'm not going to lie. So, it is absolutely something we do find. We've got either capacity in terms of being able to put the support in the first place, or even make a change or make a difference. I think some of the things that we found is actually, if there is something that we want to go and achieve, we're then looking at the data to try and understand how we can save capacity in some areas. How we can start to establish things that could be done differently or more efficiently so that we can do it once as opposed to 20 times, and therefore hopefully result in saving some capacity. And I guess that's where your sort of RPA comes in, your AI, in terms of taking away some of that administrative workload to then see what we can do differently, and having the data behind it to understand where those areas should be focused on is key. Data quality, we've definitely heard come up today. Data quality is really tricky. What we're seeing, the contracts that we hold now, locally and nationally, encouraging those points around data quality, but that is only where those contracts cover. So, unfortunately, about a year or so ago, we had really poor ethnicity data. And obviously that means when we were trying to look at things around inequalities, then it was very difficult from our perspective in terms of understanding which ethnicities weren't accessing care because we didn't have it recorded. And what was really frustrating is that some bizarre reason our contracts accepted has an ethnicity. Oh, that drives me mad. But either way, we've got over that bit now because funny enough, people putting it into the system are like, that doesn't make sense, let's actually put their ethnicity in there. So there are good drivers for it, but at the same time then, I know I've heard earlier, rubbish in, rubbish out. We really do need to look at that data literacy sort of guidance for people to understand why they need to put the right code in the first place. And I think we don't do that overly well sometimes. When we think of locums who we have a bit of a bugbear because we want them to do quaff, and they're like, it doesn't really count, I'm here for this very sheriff, I apologise to any of your locums. But they come in, they do what they need, what we need them to do, see patients, that's the key bit. So actually the contractual bits are not really on their mind as much, but actually you start to explain why we need to capture these things, why we're doing it in this way. So I don't think you would expect a lot of people to just know it. But I think there is still a massive thing around data literacy that would therefore improve data quality. The other things that we find all too often, and usually sort of stops us using data the way that we intended to be used, is the unrealistic time frames. I'm sure you've probably all come across NHS England with your ICB turning around and saying, here you go, you can bid for this contract, you've got 2 days. We'd be really good if you can put a bid in, because we'll give you 30 grand, and then what you're stuck with is, I don't really know what I need to bid on, and then the ICB comes out and says, oh, we bid on this, and you're like, that is not what I wanted. That was great, thank you very much. So that doesn't help, but I think what you do find, when you then start to have those people locally, from an analytical perspective, data perspective, that you know of what things where you can access quickly, you can then start to understand that much better, and you're a bit more prepared in terms of where your potential problems are. And I think what we get trapped into is knowing, we don't know what we don't know is a problem. That's where data does then start to help us understand that. But we also get sort of trapped in this area of, well, I know my patients, granted you do, I think things have changed slightly now in terms of as we get bigger, as we work across PCNs, as practice sizes get bigger, it's more complicated to know everybody. But obviously then what you've got is these types of tools that can say, okay, well I now know that I've got this deprived area here, I knew about that, but I didn't know that I had a massive proportion of patients with anxiety there, so you could expect that, but actually we counted that as well, so if you thought that, and you looked at one of our deprived areas, you'd be like, well actually there's a very low rate of anxiety in that area, but there's a very high rate of diabetes, and I wouldn't have expected that. And so those types of things then allow you to start to think, yes, I've got a realistic time frame, but I know I've got a big in around diabetes in an inequalities area. And then the last one's capability. So, there's an element of, and this sort of feeds into the data literacy side of it, of the capability within the practice to do this type of thing. That is a challenge. You know, we kind of all know we've got individuals within a practice that are good on EMIS or System 1 or any sort of reporting system within there. And we're not over resilient because if they then go, and we're like, oh, what are we going to do now? But we need to sort of broaden that. There's a lot more around that sort of workforce development in terms of what we're doing, how we're doing it, how do we build that further. And really encouraging that sort of development of capability across all areas. We've seen some really, really good CCIOs in general practice. We see some really good digital data champions. And I know, especially from my area, you know, we've got a GP that is fantastic. He's our GPIT lead. Everything's to a digital lead one. And I also know we've got a succession plan. And he's getting to a point where he started to think, I'm going to retire in the next couple of years. And so I'm thinking, well, what am I going to do now? Who's my digital champion? And I'm going to go and bounce ideas off, because we're not really cultivating that sort of side of it either. He's getting better now, the whole digital transformation journey, but we're starting to really enhance those capabilities across all roles. I think that's it. So, open the slides go out. By all means, email me. There's some case studies on there as well. It's all useful to see. But yes, thank you very much.
Ian, you have your hand up. Yeah.
Thank you. Yeah, I was hoping there's time for questions. So, I mean, I think really great presentation. It's good that you picked the focus on health checks and you found this sort of unmet disease that could have an early preventative intervention. One of the things I'm interested in is, could you use the same approach to look at improving the quality of disease progression prevention? So you said you excluded anybody with a pre-existing chronic disease. I'm thinking, can we start dashboarding the quality of care that's being provided to patients with a particular disease or group of diseases? And I think that the bit for me, and I'm biased because I come from Scotland, so I'm going to use some magic keywords here, but we've got this idea in Northern Board of this idea of realistic medicine, so we have that discussion with the patient about what's important to them to try and take things forward. But I think the other thing that we've seen since we abolished CROF is this idea of trying, and not managing very well because we haven't quite got the data to do it easily, but trying to take forward a quality improvement approach, either at a practice level or at a sort of, I suppose I'll translate it to RCS level, but you know, looking at the variance and looking at why that variance exists. Because sometimes you might have, I'm going to pick an example from a previous presentation, you might have a practice that is requesting pure chest x-rays, but the important thing is not that they should be doing more, but they should be asking the question, why? And I think the sort of dashboard that you're talking about will allow people to have those conversations within practices and between practices.
Yeah, no, definitely. I mean, that is a specific sort of case study of it. The actual tool, if anything, it's something we've added to the tool more recently. And so the benefit of this really is if you untick the NHS eligible filter, you're then left with any condition that you want to look at. So any sort of long-term condition, you can start to understand what that is. So is it diabetes? You can also then start to look at, we've established a couple of years ago that we've got some of our, I'm not sure if I'll work now, but frequent attenders.
High value.
Very value. Was COPD and anxiety. And it was a question of whether the one was exacerbating the other. And then this allowed us to do it. So what we can start to do then is say, well, I want to see patients who've got COPD and anxiety. And I think from memory we had about 151 patients. So then we can start to break that down further and map them out and see where they were, broadly in LSOAs, and then we can start to see, okay, well, those patients then who haven't seen a GP recently, obviously from what I've just said, we expect it to be the opposite, so we can then see, okay, are those patients who have seen a GP excessively? And then we can start to break that down further. So what that tool has now allowed us to do is really layer over different populations. So we do one for lung cancer prevalence. So we layer the whole thing over this one particular parent population, identify then, okay, well, where are they? What are the common themes across those patients? What are the healthy lifestyles of those patients? And what can we do different there? We were going to start to draw in some of that other bits then around review, so understanding which conditions are having reviews and are they well managed or not well managed, and therefore are we expecting deterioration sooner rather than later. Which is, again, easy enough for us, it's just another element to it. And I think probably the last thing that we were looking at then was, what was it? Anyway, so the idea really is that we can layer that as a way in everything. So it just enables us to really not specify one particular thing, but we could broaden out. So I'm pretty proud of that. Thank you.
There's a question at the back.
Can you hear me?
Yeah.
This is absolutely blowing my mind. You speak yourself as well. I'm a programme manager at the University of Manchester. I've been working in digital health technologies for 10 years. What struck me was your challenges slide, because that has not changed in 10 years. We're all talking about the same thing. We've all got the same challenges, and what is being done about it. Do you know what I mean? We've not really come much further in those 10 years. We can do incredible things with digital technologies, but we're working in a resource-stretched environment where we're asking staff to do something that they don't have time to do, they're not digitally aware enough to do. We're asking fantastic bunch of GPs that are interested in data. Should we not be employing data analysts in GP practices to help support that? I can tell you now they are a rare breed. We really struggle to recruit data analysts in universities, straight out of university, because industry scoops them all up. They can pay them 20 times as much as we can pay them. This is more a comment than a question. But one of the challenges that didn't appear on your slide was investment, and you mentioned 30k. I'm sure that was a figure off the top of your head. Our BRIC project has a funding of £1.3 million, and it's still not enough. 30k does not pay for a software engineer. It certainly doesn't pay for a great software engineer. You know, but again, it's a resource-stretched environment. Where are we getting that funding from to do that investment? And I think that one of the comments before was, you know, the finance is the issue. We have a whole health economic package featured into, you know, you have to show where the benefit is. You have to show if it reduces the management burden, the cognitive burden on clinicians. If it doesn't increase the burden on their time, they will snap it up. What they won't do, what we found, is trust a piece of tech that is going to take that decision away from them, because they have a professional and legal responsibility to their patients. And so if we say it's a decision support tool, they don't want something else making a decision for them. But if there's anything that can help them with the job, they will do it. Sorry, that wasn't a question.
I'm not gonna lie, but I think so. The 30k was absolutely just a sort of we can get these pockets of money that potentially could fit for. So that's kind of a good point on that. But I think I agree completely. I think every practice needs an analyst, but that's me being somewhat biased. Not gonna lie. But I think it does help that. If you've got a good relationship between your analyst or even the person, you know. I come in from practice, I full well know that no one I've ever come across in practice define themselves as an analyst. But they were also the person every day looking through the practice systems, looking at all the data, putting the reports out, giving information to telephonists to go and ring people and all that sort of stuff. They are definitely analysts. So it's been an interesting journey from that perspective. But yes, I think there is that relationship between the clinicians and that person to really enhance what we're doing within a practice is definitely valuable. Yeah, I mean, it's a challenge. The challenges themselves. It's interesting that we've all identified and all recognised those challenges. We're still doing stuff. We've all done programs of work. We've all benefited patients' lives in one way or another, whether that's individual or whether that's through a program of work. So the challenges exist, but we're still overcoming. So there's an interesting thing in how is some things not experiencing those challenges as much and other things are, and whether that's what are the levers and constraints in there that we need to pull to be able to identify that. But yes, I think it's the bottom line. Yeah, everywhere needs now.
I think we've got one more question from VJ.
Hi, that was really excellent. I'm just going to touch on the capacity part and the evaluation of capacity to make best use of clinical resources. So what about the time needed to provide the recommendations to each eligible individual? So an example of the things I've got is in a year, one GP, the total time for direct patient care is about 1,128 hours. The 167 hours needed to implement the NICE physical activity guideline is 15%. That's 167 of 1,128 hours of GPs yearly face-to-face time for patients. So if you've got those recommendations coming off your dashboard, this is more general thing as well. How do you look at that time factor if you're going to say this has been a good recommendation, it's been widely implemented, but has it been, or is it just a small amount being implemented?
It depends on which particular ones. So the tool itself can tell you that. So there's the further analysis to try and understand, what is the requirement of that time in terms of the first place. So the health check, for example, if we were trying to establish we had this many patients that needed to be seen, what's the time cost of that? And that has to obviously factor into the recommendation in terms of there's certain things that we can identify that are going to take a lot longer to do. And I guess the only thing we can really do then is balance out that value of doing that. And I think the problem we've probably heard, I think the issue that we see, or what was raised earlier, was that it's that immediate, it's giving a value now, but actually a lot of the PCN stuff isn't always about that. Obviously, health checks potentially preventing things, management care and preventing things. But when you start to look at obesity and stuff like that, trying to get people on board with the idea of what you do now is you're not going to, this is a generational thing. So how do you also, so it's almost a challenge back to extent. So how do we then provide the value and the benefit of resolving an issue, which is probably why it's been an issue for the last couple of decades, if not a lot longer, is, okay, we need to reduce obesity, but you are not going to see the value and benefit of that. Or also, you're not going to see the cost savings on that, because actually, it's going to be the next 10, 15 years, and it will be the next chief exec who's going to get all of that sort of glory and winning from these patients. So I haven't really got an answer. The only thing I would probably say is obviously what this allows you to do is obviously being able to identify the time that it could take. So actually, whereas before it's potentially finger in the air, now we can see that how many patients are there specifically in certain areas, how much time is that going to take to deliver that? But also that allows us to think, right, okay, well if I know I've got 15 patients, can I do things in a different way? Health checks maybe not, but group consultations around diabetic reviews, maybe yes, and then it just allows you to start to draw those things and be able to understand where you can make efficiencies, whereas previously you probably would have said, I've got 35 people that need a diabetic review, so therefore, in the individual practices, we'll do that ourselves, and now we're going to invite these people in this way, and actually you almost put that on its head and say, well, we can see across the PCN, you've got 100 people, why don't you do that once in a group setting, and being able to sort of reduce the time it takes. So I think, it's one of those where we can identify what values you can get from it, which helps you then build the recommendations.
Okay, thank you so much, Conor. That was really good. I'm sure hands together for him again.